Dear residents, today I spoke about oxygen therapy. So this video may be a little useful to go by basic 10 thumb rules which I will be speaking to you about oxygen. Number one, you all have to remember oxygen is a drug. It has its own indications and side effects. So whenever you choose oxygen therapy, you should always keep in mind that it has to be used as a drug. Number two, always you remember oxygen therapy means a technique by which we are increasing the alveolar oxygenations by giving oxygen more than which is available in the room air. And normally room air, is 21%. So anything which you give extra or an above FiO2 of 21, that is what is oxygen therapy, and that is given usually in hypoxic and hypoxemic conditions. Number three, basically the purpose of oxygenation therapy to enhance the oxidative phosphorylation. That means to increase the tissue oxygenation by producing more ATPs. Number four, whenever you do an oxygen therapy, always you should learn what is an oxyl delivery equation, which is a function of hemoglobin, cardio output, oxygen saturation. The three important things which you always should remember. If the cardiac output is low, the oxygen delivery in the tissues will be less. If partial pressure of oxygen saturation, which is low, that also means the oxygenation is less at the tissue level. And of course, the hemoglobin, that's the most important thing. The hemoglobin content which decides the oxygen carrying capacity, and this is what you call oxygen delivery equations, which you should always be following it. Number five, whatever the oxygenation we are taking at the room air at the sea level, that is 760 millimeter of pressure. So that means oxygen, whenever we talk of oxygenation, nitrogen, which forms the majority of the room air, it doesn't play any role in gas exchange area. So the only factor we have to deduct from atmospheric pressure is the water vapor pressure, which is 47 millimeter. So whenever we calculate the alveolar oxygenation, so we have to always keep 760 millimeter minus 47, which comes to around 730 millimeter. So alveolar oxygenation is 730 millimeter minus the oxygenation level. Larger the difference, more is the shunting. That always you have to keep. There is an alveolar oxygenation equation which you always should be referring it. And the most important thing to understand the oxygen therapy is an alveolar oxygenation ADO2 difference. That means alveolar oxygenation, alveolar capillary oxygen difference. You pick up an ABG, if you find ADO2 is more than 15-20, that means the person is going to an alveolar filling or what you call shunting. This is a right to left shunting. In a VQ mismatch like COPD or lower respiratory tract infection or and hypoxia, where you have ventilation perfusion mismatch, usually their arterial alveolar oxygen difference is within 15-20 millimeters. So that's a very important indicator. So the key points is that whenever you decide an oxygen therapy, you have to look into the cardiac status, the hemoglobin status, and ADO2 difference. The number seven, a very important thing when you talk of oxygen therapy is that respiratory rate or workup breathing. Remember, if the patient has come hypoxic to you, and if you find his respiratory rate is high, that means his alveolar ventilation is low. It is something like our alveolar ventilation is a function of the tidal volume or the volume which is going into the alveolar level multiplied by the respiratory rate. Higher the respiratory, less is the alveolar ventilation. That means less is the oxygenation. So imagine a situation, a person has come to you with an oxygenation level, we say 90%. He's probably a COVID patient and he has come with 89 to 90%. So what you have done is that you have given us here an oxygenation with 4 liters per minute. So what you have done, normally you remember there are 4 basic principles of oxygenation delivery system. The 4 principles are that the first thing is that, so the container or the reservoir from which you are giving the oxygen, whether it's a nasal flow or mask or venturi and always all these devices give you 100% oxygen. So always remember the device concentration is always 100%. It's principle number 1. Number 2, the second important thing is the peak inspiratory flow. peak inspiratory flow. That means what flow the patient is. Higher the respiratory rate, more the flow. So that means that decides the work of breathing. Third thing is then FiO2 content. What percentage of patient is breathing and developing these symptoms. Like if you're finding the patient's FiO2 is requirement is higher, that is more is the labored breathing. And the last is the what kind of delivery devices you're giving. It is basically divided into two types of devices, the fixed devices and the variable devices. The fixed devices gives you a predictable oxygenation level by the principle of Venturi effect, or what you call the Bernoulli's effect, where you have different color codes and it can give you predictable oxygenation level. Whereas variable devices, usually nasal cannula, simple mask, rebreathing mask, non-breathing mask, they don't give you the predictable. It gives you partly at rest. It comes from the atmosphere. So there's a lot of dilutional factor. Now, number 9, let's discuss a condition. Suppose a person has come to you with, say, as I was mentioning, with an oxygenation of 89%. You have seen his workup breathing is very high. Let us presume that normally you always remember the physiologically the peak inspiratory flow is 20 liters per minute. So imagine this person has come with a very high respiratory rate. So let's presume that his respiratory rate has doubled. So probably he's breathing at the rate of 36 to 40. So his peak inspiratory flow, let's decide is 40. Now what will be his FiO2? Ultimately the most important thing is that what is the oxygenation. So you say, suppose you give 4 liter oxygenation through nasal cannula. So you connect to the nasal cannula. You find this patient in no time improves his oxygenation from 89% to 96%. So what have you done? So 4 liter through nasal cannula, that means you are giving 100%. 4 liter into 100, that means 400 plus, because he's breathing at 40 liters per minute, that means 36 liters he will be taking from the room air. So that 36 liters into 21, because the room air is 21. So that number. So add up the percentage of nasal cannula into the FiO2, which is 100%, plus the room air, which is 21%, and the rest of the flow, that is 36, divided by the inspiratory flow, which is 40. So you will find whatever the number which is coming in 30s. So that is a percentage. Now you find this patient has started improving, as I told you. So his respiratory flow has come down from 40 to 20. So now what happens? The same person, you're giving 4 liters, he's taking 21 into 100 from nasal cannula. Now it has come from 40 liters to 20 liters because his work of breathing has come down. So that means he's breathing 16 liters. So then 16 into 100. So you will find his FiO2 requirement. So that means his has come down because the numerator has come down and denominator also come down. So you will find, so this person, his requirement or FiO2 is coming down. That means with the respiratory demand has come down. So what you will find, the same person is getting more FiO2 at the tissue level because the inspiratory flow, the denominator has come down from 40 to 20. So that means always you remember this FiO2 or alveolar equation. That means it is the device into 100 or number of liters of the device. Like in here we are giving nasal cannula 4 liters into 100 plus the inspiratory flow. If it is 40, that means 40 minus 4, 36 liters into 21 divided by inspiratory flow 40. If it is 20, it will be 4 liter into nasal cannula into 100 plus 16 liters, because 20 minus 4 is 16 liters, 16 into 21 divided by 20. So you will find you have to keep on calculating. So if you find the patient is improving, so you are increasing the available oxygenation. That means your FiO2, you are increasing of these patients. Now this is very important, this is relevant because if you find this patient is again degenerating or deteriorating, so what you have to do is that suddenly we find from 20 liters gone into say 40 liters or 60 liters. So what you have to do, now you have to change the nasal cannula into something more deliverable. Suppose you give rebreathing mask for 15 liters. So what will happen? 15 liters is coming to the rebreathing mask into 100, which is 1500. Plus, since you are giving now 4 liters to 15, so what he will do, he will take less from the room air. So his flow will come down 40 minus 15, say he's breathing at again 40 liters per minute. So it will be 25 liters. So you will find you are giving more FiO2 because by giving more liters through devices, you're increasing the FiO2. So this is how you have to calculate. Now, so you have to understand what exactly. Then, so the key thing is that whenever you decide on oxygen therapy, you have to see the overall clinical. So I think the 5 things you should look is that clinical history, the anemia history, the cardiac history, cardiac rate, respiratory rate is the most important. If you see the bedside respiratory rate is very tachypnea, that means the patient has a high inspiratory flow. Then also you have to see whatever the device you are using, can you achieve that oxygenation, achieve the oxygenation which is targeted, the normal oxygenation. So if you have achieved the oxygenation and if you are able to reduce the work of breathing, that is your device. If you find anything worsening, that means you have to go for something from variable to non-variable, which is called fixed, which is called Venturi. Venturi works on the principle of Bernoulli's principle, where we have intermittent probes. So it gives you a very fixed, predictable oxygen at the alveoli. So that means there is no entrainment, there is no dilutional of the air from the atmosphere. So that means if you are giving 24, that means you are giving 24, you are giving 28, you are giving 28, like this 24, 28, 36, 44, like this you are giving it. So there are different Venturis have different flow rates. You should always read the colors. So light blue is the lowest color, which is 24%, and the highest is that little on the bluish side, which is around 44%. So you can read how much of the flow, what is the flow rate in the entrant probe requires it. So if you really want to give you a predictable oxygenation, that means you have to give for the Venturi defects. Venturis. So you have to identify the Venturis and see the predictable. And always you have to see based on the thing, because there are 2-3 things that are very important in oxygen therapies. And one is, as I told you, all these cardiac parameters and anemia and other factors. Another very important is an oxygen dissociation curve. So always you have to keep in mind whether this patient is acidic or alkali. Many times what happens, the patient is hypoxic, patient is hypercapnic respiratory failure. Sometimes it's preferable to give them hypoxic to have the drive. If you over-oxygenate and increase the oxygenation and saturation, so what will happen? They reduce their drive and they go into hypercapnia, because hypoxia causes a rightward shift of the oxygen dissociation curve, and that causes increased extraction at the tissue level. So always you should keep in mind what are the factors which affects the oxygen dissociation curve. The rightward is increased 2,3 GP, decreased pH, and decreased oxygenation, which reduces the rightward shift, and the leftward shift, alkali causes leftward shift, reduced DPG causes leftward shift, and of course increased temperature causes right. So in always you find in that patient who are hyperpyrexia or hypothermic, usually they have a rightward shift. Sometimes their oxygen extraction is good. So always you have to use your clinical wisdom. What exactly you're seeing? What is the background? What is the heart rate? What is the hypoxic drive? And most important, you have to see the respiratory rate. Ultimately, you have to target the respiratory rate. If you can bring down the respiratory rate to minimal, that means whatever the devices you're using, that is the right. So friends, always keep in mind all these 4 factors to recap. What is the device you're using? What is the flow rate the patient is breathing in? What devices you are taking it? And what is the FiO2 which you are giving? That is very important. And always you have to see the patient as a whole. You have to see other pictures, what you are doing, whether you're trying to treat the vacuum mismatch vis-a-vis the shunting. So depending on the things, if you find a patient is shunting, especially in pneumonias or in cardiac shunt, so there you have to give a fixed delivery device, the Venturi's principle. So Venturi's give you much more predictable, but through through variable system like nasal cannula, rebreathing mask, and non-breathing mask, you can go up to at 90%. Only thing flow rate is to maintain around 15 liters. But the problem is that non-breathing and rebreathing mask, the problem is that with the rebreathing mask, there's a tendency for a hypercapnia or a CO2 retention. But in rebreathing mask, you can achieve the oxygenation level very high, depending on your CJ situation. If the patient is very hypercapnic, don't use this rebreathing mask. Go for nasal cannula if it is not possible. Then if you find the respiratory is worsening, shift to the high flow. If you find the oxygenation is not improving, I think whenever you find high flow, hypercapnic, hypoxic patient, you should immediately go for the Venturi devices. That's my take. Follow your clinical wisdom, follow all those basic rules, and you remember there's all different types of hypoxia, different management, and it is that hypoxia where the oxygen therapy plays the most important. In anemic hypoxia or tissue hypoxia, what you call anoxic hypoxia or histotoxic hypoxia, or there is a decreased flow, what is called stagnant hypoxia because of low flow, their oxygenation tissue doesn't help. There you have to use the volumes, you have to take care of the hemoglobin, you have to take care of other things. So oxygen therapy only works in hypoxic hypoxia. So this is a little take home, whatever I spoke today in today's tutorial, that I'm giving in audio format and audio video format. So through a YouTube link, this may be useful to you. Thanks, regards, Dr. Bose, Senior Consultant and Faculty Pulmonologist, National Heart Institute.